Chronic venous insufficiency is still a disease with a high incidence in Western industrialized countries. According to a current epidemiological study by the University Hospital of Bonn, 23% of the population in Germany between the ages of 23 and 79 have received treatment for this disease, with 7% of the population having undergone an operation. Varices of the legs are often related to incompetent valves in the greater or lesser saphenous vein. Clinical symptoms, together with functional tests like digital photoplethysmography or color-coded duplex sonography, allow us to draw conclusions on the extent of the disease. If left untreated, the condition might deteriorate until the patient is suffering from ulcers, or until acute complications like varicophlebitis or thrombosis develop. The first-line conservative treatment of chronic venous insufficiency is compression therapy and elimination of pathological refluxes. Besides traditional sclerotherapy and classic varicose vein surgery with high ligation and stripping of the incompetent greater saphenous vein, new endoluminal techniques have been developed in the past years. After foam sclerotherapy and RF sclerotherapy, the endovenous laser treatment ELT is the latest therapeutic option. Dornier MedTech Laser produces various laser devices for endovenous laser treatment. The Medilas D Compact is a small portable laser device which emits up to 30 watts of laser power. The Medilas D-Skin Pulse is a high-power laser with pulse power of over 80 watts. This power additionally allows the treatment of spider veins. For endovenous laser treatment, diode lasers with a wavelength in the near infrared between 800 and 980 nanometers are used. The Dornier diode lasers emit the wavelength of 940 nanometers because of its optimal absorption properties in the hemoglobin. This spectrum shows the penetration of light in blood in the range from 400 to 1000 nanometers. The wavelength of 940 nanometers has a penetration depth of about 300 micrometers. This minimal penetration depth leads to a strong thermal interaction of laser light with blood. This is demonstrated in the following experiments. When irradiating the surface of blood with short laser pulses, the laser light is absorbed by a very thin blood layer at the surface. Only low pulse energy is necessary to vaporize the blood. Smoke and water escape unhindered into the atmosphere. The smoke is generated by the burning of organic blood components as a reaction with oxygen in the air. The situation changes, however, when laser radiation is applied directly into the blood. A thin laser fiber is dipped into a glass tube filled with blood to simulate an endovenous laser application. If short laser pulses, here 1 second pulse duration, are applied, The blood heats up briefly and produces a steam bubble. This bubble condenses back to water immediately after the end of the laser irradiation. The burning of blood components is largely prevented due to the lack of free oxygen. Blood proteins are coagulated due to the heat produced. The size of the laser-induced steam bubble has been measured in an in vitro experiment. The diagram shows that beyond a certain threshold value, the size of the steam volume increases linearly with the applied pulse energy. For the pulse energy of 15 joules, which is used clinically, the steam volume is about 18 cubic millimeters. A vein compound stripped immediately after endovenous laser therapy shows macroscopically visible tissue changes induced by the laser pulses applied 5 millimeters apart. Focal erythema due to local damage and individual small perforations can be seen. Histological examination basically shows two types of laser-induced damage. Firstly, the site of direct laser impact in the vein wall is damaged. Even more important, however, is the surrounding damage. The destruction of the endothelium and heat damage to the inner vein wall as indicated by the edematous swelling of the collagen fibers. Endovenous laser treatment has been carried out in Mainz, Germany since March 2001, in most cases on an outpatient basis. All patients are examined phlebologically and are informed about the treatment. This patient showed up at the scheduled time and is now being asked to change her clothes in the changing room. Over the last few years, the patient has developed smaller tributaries at the left lower leg and moderate edema after orthostatic challenge. The patient's clinical status was C2 to C3. Furthermore, duplex sonography showed a truncal varicosity of the greater saphenous vein with refluxes down to below the knee, certainly requiring surgical correction. For endovenous laser treatment of the greater saphenous vein, the following instruments are used: an 18-gauge needle for vein puncture, a 0.038-inch J-tip guide wire with a length of 150 centimeters, a 5 French angiographic catheter with a length of 100 centimeters, and a Dornier light guide with a bare fiber tip, core diameter 600 micrometers. The laser device used is the Dornier Diode laser Medilas D compact with a wavelength of 940 nanometers. The greater saphenous vein is punctured below the knee. The puncture is facilitated by ultrasound B scan. If necessary, a tourniquet is placed at the thigh to increase the vein's diameter. Ultrasound control allows the needle to be observed penetrating the vein. Thus, the puncture can be performed more quickly and safely. The laser light guide is positioned according to the Zeldinger technique. After being flushed with heparin, the guide wire is inserted through the sheath in a proximal direction up to the saphenal-femoral junction. The position of the J-tip can be controlled by ultrasound imaging. Now, the catheter is pulled over the guide wire. Afterwards, the position of the catheter tip is controlled via ultrasound. The distance from the tip to the saphenofemoral junction is measured and documented. The guide wire is withdrawn. To prepare the laser application, the laser light guide is connected to the device. The visibility of the aiming beam is checked to prove the functionality of the light guide. A sterile fiber stopper is placed on the sterile fiber. Afterwards, the light guide is inserted into the catheter. The fiber stopper must be fixed tightly onto the fiber in front of the catheter. This is to prevent the fiber from slipping back into the catheter while pulling back the catheter. The fiber tip can clearly be seen in the ultrasound image. With the light switched off in the operating room, the scattered light of the red aiming beam can be observed through the skin, if the tip of the light guide sticks out of the catheter. The visibility of the red aiming beam is an important control to check the location of the fiber tip in relation to the catheter tip and to ensure that the fiber tip is outside the catheter. The next step is the administration of the tumescent local anesthesia. It basically consists of an alkaline buffered isotonic saline solution with 700 milligrams prilocaine and 1 milligram suprarenine per liter. It is injected perivenously around the greater saphenous vein. A roller pump makes it easy to inject the anesthetic quickly. The injection is also carried out under ultrasound control to ensure the sufficient and targeted application of the anesthetic. The additional advantage of the tumescent local anesthesia is the buffering effect of the injection fluid on the vein. The fluid is a cooling reservoir around the vessel and therefore almost completely prevents damage to the nerves. The compression effect reduces the vessel diameter to optimize the effectiveness of the laser treatment. The laser radiation can start immediately after applying the local anesthetic. The laser parameters are adjusted at the touch screen. The setting is a pulse mode with 1 second pulse duration and 1 second pulse interval, as well as a laser power of 15 watts. Recently, the laser energy has also been applied with 15 watts continuous laser power while the fiber is being continuously withdrawn. The laser irradiation starts proximally at a distance of 1 to 2 centimeters from the saphenofemoral junction. During pulse intervals, the catheter and the light guide are each pulled back 3 to 5 millimeters in a distal direction. The laser operation is accompanied by a warning sound as acoustic feedback. The number of applied pulses is shown on the touch screen of the laser machine. Depending on the length of the vessel, about 70 to 100 pulses are applied. The vein is irradiated intraluminally down to a point as close to the puncture hole as possible. The aiming beam should always be visible through the skin. The mode of action of the laser irradiation is also visible in ultrasound. Here, the ultrasound echo shows small steam bubbles as a clear trace of the laser fiber, which is continuously being withdrawn under continuous laser emission. The condition of the fiber tip is checked once more at the end of the laser treatment. The quartz fibers used have proven to be very reliable and resistant. No breakage of the fiber tip has so far been observed. The entire operating time was about 30 minutes. Up to November 2002, more than 200 operations had been performed on the greater saphenous vein, and more than 50 operations on the lesser saphenous vein. The maximum post-operative surveillance time is approximately 20 months. A primary occlusion rate of about 98% was achieved. 5% of the vessels recanalized within 6 to 12 months of the operation. Of the 102 cases performed with intermittent laser irradiation and step-by-step withdrawal of the laser fiber, 74% of the patients showed ecchymosis lasting for about 2 weeks. Pain along the leg or palpable indurations were observed momentarily. Thrombophlebitic reactions could be seen in about 10% of the cases. Only 2 patients experienced transient paresthesia. Post-operative care for our ELT patients is similar to that usually carried out for sclerotherapy. That means the patients wear compression stockings day and night for 8 days. For safety reasons, we also take precautionary measures against thrombosis according to the patient's personal risk profile. The eccentric compression bandage can be removed after 1 or 2 days after the operation, which brings relief to the patient. Patients should walk and move immediately after the operation, and we recommend that somebody takes them home and that they are not left alone during the first 24 hours. Class 2 compression stockings should be worn by the patient for 24 hours a day over 8 days. Keeping in mind the short surveillance time after the treatment of 18 months, the endovenous laser treatment can be rated positively. It has proved to be a real new alternative to other treatment options. It can be performed in an outpatient setting. It saves time, has few complications, and yields excellent cosmetic results. The short period during which the patient's professional and daily life is affected, and the very low post-operative impairment makes this method of interest to elderly patients as well. Next morning, the patient came back for the first follow-up. She had a good night with no lasting pain. Ultrasound imaging is performed to verify the occlusion of the greater saphenous vein. The ultrasound image clearly shows a thrombotic occlusion of the vein near the saphenofemoral junction. The distance between the occlusion and the saphenofemoral junction is measured and documented. The endovenous laser treatment, ELT, was very successful, and the patient is highly satisfied. She will be back in 4 weeks for the next follow-up examination.